Good afternoon, everybody. This is Dr. Sandhya Singh, the chapter convener of IDA Bangalore chapter. I'm extremely happy to be conducting this RD internship presentation. Our RD representative, Mrs. Daphne Balan, is with us, and she will be just taking you all through the presentation of today. We have three students. Ma'am will be doing the introduction. So a warm welcome to you, Daphne ma'am.
Thank you, Sandhya. Thank you so much. Okay, students, thank you for being here. And it's cases per student. So we'll start off immediately. And I think you can take about 20 minutes each so that we finish on time. Okay, there'll be questions at the end of both the cases. So wait for one student to finish fully and then we can ask any questions that we have. Okay, thank you. So who will be starting first?
Ma'am,
Aishwarya, Arsala, Dafina?
Aishwarya.
Aishwarya. Okay, start.
Can I start, ma'am?
Yeah. Aishwarya?
Ma'am, I'm sharing,
Okay, okay. I thought we lost you. Okay.
No, it's loading, ma'am.
Yeah, okay.
Can you see, ma'am?
Yes, now we can.
Okay, ma'am.
Yes.
Good afternoon, all. I'm Aishwarya. I have, can you hear me, ma'am? Hello, ma'am. Good afternoon, all. I'm Aishwarya. I have completed RT internship from Apollo Hospital, Bangalore. Today I have two case presentations on rhabdomyosis and anemia. First, I'm going to start with rhabdomyosis. First introduction. It is a rare muscle injury where muscles break down, and it is a life-threatening condition that can happen after an injury or excessive exercise without rest. It is a condition that causes the muscles to break down, which leads to muscle death. When this happens, toxic components of muscle fibers enter the circulation system and kidneys. It can cause the kidney damage also. Then the causes are like high intensity exercise, severe dehydration and overheating, injury or trauma, medications, and long periods of inactivity. Now coming to the signs and symptoms. Muscle swelling, weak muscles, tender and sore muscles, dark pee that's brown, dehydration, decreased urination, nausea, and loss of consciousness.
Aishwarya, the slides
Yes,
are
ma'am.
not moving.
Now it's moving, ma'am.
No.
No, not moving.
But then, ma'am, I'm changing the slides.
Don't change.
You
Click
do.
on the left slide. Click on the slides in your left corner.
You click on the slides, one, two, three, then it will show up.
Is it coming,
Click
ma'am?
on the second slide now.
What, ma'am?
Click on the second slide.
Ma'am?
Don't move. Just click on it.
See, do
Is it
not
fine?
go to the slideshow mode. Go to the slide sorter mode.
Yeah,
Now we can
yeah.
see. Now we can see.
Okay, got it?
Ma'am, is it
Yeah.
fine?
Yeah, now
Yes.
we
Now
can
we
see.
can.
Okay. Ma'am, can I continue?
Yes,
Continue,
continue
please.
with signs and symptoms. Yes.
Then signs and symptoms like muscle swelling, weak muscles, tender and sore muscles, dark pee that's brown, dehydration, and decreased urination, nausea, and loss of consciousness. Now, coming to the complications, it can happen kidney damage or failure, electrolyte abnormalities, metabolic acidosis, disseminated
Aishwarya,
intravascular.
click on the other slide again.
Now, also, it's not moving, ma'am.
No, it's not.
It's not moving. Go to the next slide. You click the slides.
Ma'am, it's fine now.
Now we can see your clinical data, but you have not completed your previous
Yeah, ma'am.
slides. Go to
Can you see that?
complications. Yes,
Yeah.
now we can see.
Okay.
So on the left hand side, you please change the slides and then go ahead.
Okay, ma'am. Okay.
Okay.
Now, the complications are kidney damage or failure, electrolyte level abnormalities, metabolic acidosis, disseminated intravascular coagulation. Now, the diagnosis, clinical history and symptoms. By laboratory tests, we can find the diagnosis, urine test, imaging, like MRI and ultrasound scannings. Now, the treatment and management, by receiving fluids and electrolytes intravenously, this fluids will flush out the toxins from the system, and correction of electrolyte balance, dialysis if there is a severe kidney damage, and proper hydration. Now, coming to my case study, the patient, he was a 14-year-old male. He was from Karnataka, and he got admitted on 19th of November and got discharged on 25th November. And the hospital stays, number of hospital stays were like around 7 days. Now, coming to the clinical data, the patient came with a history of vomiting episodes of around 80 to 20, abdominal pain, pain over the bilateral thigh in past 2 days, decreased urine output since 3 days, and history of strenuous physical activity for 1 week. Now, the past medical history, nil. Now, the final medical diagnosis, rhabdomyolysis, acute on chronic kidney disease. Diagnostic criteria was creatinine kinase test, serum test. It was very high during the hospital ICU stay. Now, coming to the vitals, temperature 98 degree Fahrenheit. Then the pulse is 70 beat per minute, and respiratory rate is 20 beat per minute, and BP is 110 bar 70 mmHg. Now, coming to the anthropometric assessment, his height was 170 and weight was 60, and BMI was not applicable here. Now, coming to the biochemical parameters and blood CBC reports, almost all were okay. Like, it was not that elevated, but coming to the uh, sodium and glucose, it was low on the first day, because the past 2 3 days he was not able to take food, and whatever the water water also he was vomiting, and his glucose level was so low that day. Then urea, uric acid, creatinine, potassium, creatinine kinase were high, and it is due to the muscle breakdown which makes the potassium, creatinine leak into the bloodstream, making the parameters high. Now, the dietary assessment, renal type of diet is renal diet, food preference non-vegetarian, food allergy nil, and meal pattern is 5 to 6 meal pattern. Now, coming to the medications, during the hospital stay, he was taking isotonic bicarb, tablet Heptral, tablet heparin, injectant ceftriaxone, throm 4 ointment, and cabmagneol. Then potassium bind sachet, injection pan, injection set, injection Bucomis, injection dextrose, tablet Shirkal, and syrup UK check. And at the time of discharge, he was advised to take tablet pan and this um, capsule Magvio. Now, coming to his hospital home recall, this is his breakfast mid morning, and again mid morning he used to have the same breakfast from his school or wherever he is, and lunch. This is evening snacks and dinner and all. And calorie here comes around 1344.22 kilocalorie. Carbohydrate it is 231.39 gram. Protein 52.82 gram. Then fat 12.66 gram, and sodium 384.48 mg, and potassium it is 2163.9 mg. Interpretation about his home recall. Generally, his intake was good. He used to take fruits, vegetables regularly, and like the fruits and tubers, green leafy vegetables, and all once or twice in a week. But then his dinner intake was like very late, around 10 p.m., and he eats some snacks at the late evening. And this is his food frequency questionnaire. Cereals, millets, pulses, other vegetables, fruits, fats, oil, sugar, everything he takes generally daily. Then green leafy vegetables, fruits and tubers weekly. Milk he takes rarely only. Now this is the case progression in the hospital. From 2020 to 25th, he was maintaining the renal diet. This is the approximate calorie and protein. Now coming to his hospital recall. Initially, his intake was in hospital was very less because due to the pain, medication, and the ICU stay and all. Then once the symptoms got subside, he started to feel better, and he gradually increased his intake also. Here, calorie was coming around 1406 and protein of 49, and carbohydrate 169.5, fat 28.2, sodium 293.2 mg, potassium 1893.6 mg. The best statement. Problem was he came with vomiting and severe thigh pain, and etiology is a strenuous exercise, and signs and symptoms comes muscle weakness and decreased urine output. He was a patient who was doing karate from from 4 years onwards. He was doing this karate, and in the last like before the admission, the last 1 week was he was doing so much of exercise because of one exam in karate. So then after 2 3 days he started severe pain and vomiting. Now coming to the diet prescription. Energy is 1500 kilocalorie, 25 kilocalorie per kg per body weight was given. Carbohydrate 206.2 gram, that is 55% of calories. Protein 48 gram, 0.8 gram of gram per kg per body weight. Fat 33.3 gram, 20% of calories. And salt is 3 gram per day. Now coming to the MNT, medical nutrition therapy, energy was recommended around 25 to 30 kilocalorie per kg per day. Less protein diet is recommended here, that is 0.8 gram per kg per day. Sodium restriction is recommended. Then lowering dietary potassium intake to maintain serum potassium level within the normal range. Low phosphorus, low fat diet. Now the nutritional goals. Short-term goals are like electrolyte management, muscle pain, cramping management, protein management, and long-term goals like prevent renal dysfunction, ensure adequate fluid intake. Now coming to his exchange list, cereals were given around six number, pulse 2, and milk 4, and other vegetables 4, for one fruit, and oil of 3. Now coming to his discharge diet, the prescribed diet plan. This is the plan. Now the recommendations. Small and frequent meals throughout the day were recommended. Limit salt intake to 3 grams per day. Avoid sugar and processed items. Avoid fats that are solid in room temperature. Low sodium, potassium, phosphorus foods to be maintained. The electrolyte balance and less protein diet. Adequate intake of fluid as per doctor's advice. Now, the discharge advice that foods to be avoided: millet and its products, tender coconut water and coconut gravies, fruit juice, aerated drinks, packed beverages, deep fried bakery products, mixtures, bun puffs, etc., red meat, egg yolks, prawns, beef, pork, mutton, organ meats like brain, like liver, kidney, and all. Preserved foods also to be avoided, like the sauce, cheese, and all. Remove cream from the milk, curd, and all. Avoid consuming green leafy vegetables. Now the follow-up. Patient was reviewed after the 10 days and he was following the recommended diet plan, that is renal diet. At that time he was having fever and his intake was little less. Then again after 10 days, like renal uh, on 15th he was follow up. Then the renal function test was almost all normal except for creatinine, which was 1.34. And at that time he was doing started doing some little exercise as advised by the doctor also. These are the references. Thank you. Now, 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 ma'am, can I present the other?
Yes. Yes, Aishwarya. You can go to the second one.
Okay.
Is Daphne ma'am there? Daphne ma'am, should we take the questions and then move on?
I think, yeah, fine, Sandhya. We'll take the questions and finish off.
Sure. Otherwise, the questions might get jumbled
Pile up.
up.
Yeah.
Yeah.
So, Aishwarya,
Yes,
why are you saying BMI is not applicable?
he's a 14-year-old boy, ma'am.
Yeah.
Uh,
So, there are other ways of calculating for a child, right?
yes, ma'am.
So, BMI or some kind of IAP standard could have been used to tell us whether he is normal or underweight or not healthy or something.
Yeah, ma'am.
There are standards for even 14 years old. Okay.
Yeah, ma'am.
So find that and fill it in. Don't write not
Okay.
applicable.
Okay,
Okay.
ma'am.
Okay. Then one more thing I saw. Can you go
Uh,
back to your prescribed
yes.
menu, please?
Prescribed menu, ma'am.
Yes, yes.
Uh,
Yeah, yeah, this one.
yes.
So how did you modify for this kind of a patient? Meaning, what did you concentrate on?
I concentrate to give a less protein diet.
Less protein. Okay.
Yes. Less protein diet, but then he needs some calorie also.
Yes, yes, yes. Protein has to be a certain amount.
Yeah.
Go to the next slide. Next slide. Okay. Next one. So, what are your protein sources? Because when you rush through, nothing
Mm,
caught my eye saying, okay, some amount of protein. I think only here wheat and some amount of curd is there.
milk. Yes.
No, you can
Milk. Yes.
concentrate on high quality protein, but less.
Yes, ma'am. At
Okay,
that
yeah.
time, his ma'am, can I tell?
Yes, yes, tell, I'm waiting.
During discharge, his creatinine discharge time, his creatinine was high.
Yes.
So at that time, we asked not to take egg whites because the
Mm.
creatinine was like 2.2 above.
Okay,
So at that time, we asked like for a certain weeks to avoid the egg and all, non-veg.
okay, but not even milk, is it? I'm not seeing milk also here, only
Milk
curd
is there,
twice.
ma'am. Milk is there,
That's what
ma'am.
I, you're fast, so we cannot. Where, show me
Evening,
milk?
yeah, evening it's there, morning is there.
Oh, milk, that corner. Okay, okay. Okay, 100. So, how much milk and how much curd have you given the whole day? Go back to your
Uh,
exchange, go to the exchange list.
four
Yeah,
portion.
yeah. Milk is 4, milk and curd. So, you've completely avoided non veg.
Yeah, yeah. For certain days, I have avoided the non-veg.
Okay. And go to your oil calculation. Go to the last, no, the last slide of your prescribed.
Okay.
Somewhere you wrote oil. 15 grams or ml is not 45 calories. isn't it?
Yes, ma'am.
So just correct that also. Okay.
Okay, ma'am.
Yeah. So you'll fill in the Na correctly. You'll fill in this oil calculation, and
Yes.
yeah, you explained about the proteins.
Okay, ma'am. Okay.
Okay. So he left the hospital with his kidney in better condition. You're saying.
Yeah, ma'am. Like
Okay.
parameters were so high when the time of
Yeah.
admission,
So it
but
came
then
under
it was
control.
gradually improving.
Okay. 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 Fine. Thank you. That's what I had to ask.
Thank you, ma'am. Ma'am, can I start with the
Yes.
other?
Please go to anemia. Yes.
Okay, thank you. My next case presentation is on anemia. Introduction part, it's a deficiency of red blood cells or hemoglobin in the blood, which leads to reduced oxygen transport to the body's tissue. And coming to the causes of anemia, you know that inherited red blood cell disorders, chronic diseases, deficiency of nutrients like iron, vitamin A, folate, and B12 vitamin, heavy menstruation and pregnancy related issues, HIV, and parasitic infections. Now, coming to the symptoms, it's fatigue, headache, yellowish skin, irregular heartbeat, chest pain, cold hands, dizziness, leg cramps, and insomnia. Now, the types of anemia are like iron deficiency anemia, megaloblastic anemia, pernicious anemia, thalassemia, sickle cell anemia, and aplastic anemia. Now, coming to the complications, weakened immune system, impaired development, issues with pregnancy, heart problems, and increased risk of infections. Now, diagnosis, the complete blood count test, hematocrit test, hemoglobin, peripheral blood smear test. Now, this is a picture of a normal amount of RBC and a patient who having anemia. Now, the treatment comes by diet. We can improve vitamins and drugs and blood transfusion. Now, coming to the case study, uh, Mr. ABC, like the patient, he was a 21-year-old male. He got admitted on 3rd of October and discharged on 5th of October. The number of hospital days were 3 days. Now the clinical data, patient came with a cough, excessive exhaustion, history of one episode of loss of consciousness last week, history of intermittent giddiness, breathing problems while climbing stairs and fatigue. He don't have any past medical history. Now final medical diagnosis was like megaloblastic anemia. The criteria of diagnosis was vitamin B12 test and his HP was also very less. Now the vitals 98, temperature is 98 degree Fahrenheit, pulse is 120 beat per minute, and respiratory rate is 40 beat per minute, and BP comes 108 per 70. Now coming to his anthropometric assessment, his height was 176 centimeter and weight is 80. BMI comes 125.82 kilogram per meter square. He comes the category of overweight and ideal body weight was 76. Now coming to his biochemical parameters, this is the HP level in the hospitals and on the follow-up day. When on the first day it was 5.2 only, then the parameter, the CBC reports are here, which all were rearranged like almost. The vitamin B12 was also very less. Then the second day, like first day itself, the blood transfusion was done around 10 PRBC. Now coming to the dietary assessment, the diet was balanced diet, no food allergy. He was a non-vegetarian and his meal pattern like 5 to 6 meal. Medications. These are the medication he was taking from the hospital: syrup Prostrex, tablet Imisat, tablet Montec, injection Monosef, tablet Heptral, injection Ervichen Plus, tablet Pan, Neurokin, and IVF MS. Neurokin he was taking after the discharge also for 1 month, like alternate days. Now this is his 24-hour home recall. Comes the breakfast, then lunch, evening dinner, nutrition calculation of his home recall. Energy comes around 1148.3 kilocalorie, carbohydrate of 275.04 gram, and protein 49.1 gram, fat 15.2 gram, iron 8.8 mg. Interpretation about his home recall. His conception of iron rich foods were not seen, and fruits, eggs were also not included. He was a hostelite, so the green leafy vegetables and all he was not getting from there also. Then the food frequency questionnaire: cereals, millets, pulses, roots and tubers, other vegetables, fats, oils, everything he was taking on a daily basis. Animal products and outside food weekly. Then the green leafy vegetables and fruits, he never takes. Fruits he don't likes. That's what he was telling. The case progression in the hospital, like from day 1 to day 3, it was a normal diet. Then this is the approximate calorie and protein, and this is his hospital recall. He was eating a proper diet from the hospital, like his appetite was fine after, like the second day it was fine, from second day onwards. The calorie comes to 1500 here, and protein of 59, and carbohydrate of 242, fat of 12.8 gram, and iron of 16.9. Now his test statement, he came with a giddiness, and the etiology is like low vitamin B12 level in the blood, and signs and symptoms like breathing problems while climbing the stairs and fatigue. Now the medical nutrition therapy: consume non-iron sources with a source of vitamin C. Eat lean meat, fish, poultry regularly like at least 2 times per week. Eat enriched grain products. Add green leafy vegetables in diet. Add dried fruits in diet. Avoid tea, coffee, cocoa. Have high amount of tannins and oxalates, which inhibits the absorption of iron. Now, these are the iron-rich sources in the food groups of vegetables, cereals, grams, pulses, fruits, nuts, and seeds. Then the non-vegetarians and sugar products and all. These are the sources. Now, the goals of management: short-term goals like improve the dietary intake to increase the hemoglobin level. He needs a good diet, like his intake should be improved. Then assess the underlying causes and enhance the energy level. Long-term goals like nutrition stability, regular monitoring, and he need to educate about the importance of the iron-rich food and all, and prevent recurrence. Now this is the diet prescription. Energy comes 1596 kilocalorie, 21 kilocalorie per ideal body weight. Proteins of 76 gram, 1 gram per ideal body weight, and carbohydrate 219 gram, that is 55% of the calories. Then for fat of 44.3, that is 25% calorie of the total calorie. Then iron, it comes 19 mg. That day is 19 mg for men. Then exchange list, here 8 portion of cereals were given, and the pulse was 3 portion, milk of 4 portion, other vegetables of 4 portion, fruits 2 portion, oil, sugar, non-veg, and even both to oil 3 portion, and sugar and non-veg 2 each. Now this is a discharge diet modified, like early morning to day, bedtime I have modified. Now the recommendations are like take small and frequent meals, add iron-rich food items in diet, include vitamin C and B12 rich food in diet, avoid tea or coffee while taking iron rich foods, avoid prolonged cooking, avoid outside food and processed food, engage in gentle exercise to maintain your overall health, keep hydrated. Then this is his follow-up. On 13th of October, he was called and asked about his dietary pattern and like his intake, appetite, and all. He was like he improved his dietary pattern and started including the iron-rich sources whichever he can. And this on 16th, he got checked his HP level, and it came to around 12 mg per deciliter. And these are the references. That's all, ma'am. Thank you.
Thank you, Aishwarya.
Thank you so
Aishwarya,
much.
can you go back to your assessment where you wrote down the NA?
This one, ma'am. As ma'am.
F1. Okay. No, where you wrote his ideal, his weight and height and,
Yes, ma'am. Yes, yes.
yeah. So, uh, what do you assess this patient as?
Ma'am.
What is your nutritional diagnosis or nutritional assessment of this patient?
Yeah,
You've got
ma'am.
all the figures here, it's all correct. But what
Yeah,
is
ma'am.
your assessment?
Assessment, like, the thing is that he was a patient who was taking a proper, not proper means
No, no,
he was
no,
taking
no, no.
a,
I'm saying, see, you've got his BMI as 25.
yes, ma'am.
Okay.
Uh,
What is his assessment? You must say whether he is normal, overweight,
yeah, ma'am.
underweight, obese. Or
Yeah, it's overweight, overweight.
so you must write that. When you're
Okay.
writing on top assessment, his nutritional assessment will be overweight or
Yeah,
obese,
yes.
whatever.
Uh,
You have to add one more row there, okay?
okay, ma'am.
You just giving this information will not tell another dietitian what is this patient's, or it may tell a dietitian, it won't tell a common man what is his assessment. You
Okay,
have to
ma'am.
write that word down, what you have
Okay.
inferred from this information, okay?
Okay, ma'am. I'll change.
Yeah. No, I'm just giving you all this
Yeah,
information,
ma'am.
okay? Then again, you have written oil 15. I don't know, are you understanding it wrong or are you writing it wrong? Oil, you're saying 15 grams is 45 calories? I think
Yeah,
you
ma'am.
meant 5 grams.
Yeah, it's 5 gram, ma'am.
Yeah, okay. So again, you made that mistake here
Yeah.
also. Then go to your planning diet, your prescribed diet. Yeah. Calculation. Go. Further, go up, go up. One more slide, go up. No. Previous slide. Previous. No, I want the calculation. Go previous, the beginning of this.
Okay, okay, ma'am.
Yeah. How did you get 1596?
I've calculated with his ideal body weight,
So ideal body weight into
21 calorie.
why 21?
He's actually overweight.
No. Who gave you this guideline saying multiply by 21? Why not 20? Why not
If
23?
if I'm giving 23 and all, it's coming so high, like a big high value.
No.
So it
See,
will.
I know what you girls do. You all are doing it ulta. You're getting 1596 and then you're saying how many calories to multiply it by, isn't it?
Correct, ma'am. What you're
Yeah.
saying is correct. They
So
are
you
not
girls,
arriving at the figure. Whatever they
yeah.
are getting, they're trying to divide it by the ideal body
Then
weight and
you're
get
not,
it.
then you're correct. Then you're afterwards you all are writing how many calories.
Yes.
So this patient's ideal body weight is 76.
Yes, ma'am.
You must follow some guideline which says even if it's 20, it doesn't matter because 21. First of all, it catches our eye because no one has a guideline of 21 kilocalories. Secondly, it is not the way to do it.
Okay, ma'am.
Okay. So correct that also.
Yeah, ma'am. I will check
And
that.
then, yeah, then go to your protein. Just go to the next slide. Next slide. Slide here. Fruit. Which fruit is giving you 20 grams protein, Aishwarya?
Oh, sorry, ma'am. It is. Oh, ma'am, it is
Okay.
wrong.
Fine.
Sorry.
If it's a mistake, just correct that
Yeah.
also. That's what I had. Protein 220, 21. Yeah. That's all I had to ask you. Okay. So please correct this and show it to Sandhya ma'am again.
Sure, ma'am. Sure, ma'am. Sure.
Okay. Okay. Thank you, Aishwarya.
Thank you, ma'am. Thank you so
Well
much.
done. Thank you. Thank you. Okay. Defina, you're doing it next. Are you presenting next?
Yes, ma'am, I will present.
Okay. Thank you. I will go off. This.
Just wait a second, ma'am. Is it visible, ma'am?
Yeah. Now it
Hello.
is. Yes. Now it is.
Am I
Carry on.
audible?
Yes. Yes.
Okay. So good afternoon, everyone. My name is Dafinia Santafi Kashanlar, and I'm an RD intern from Apollo Hospital, Banargata. So in today's presentation, the topic that I'm going to present is a pre-eclampsia with a pre-existing chronic kidney disease on hemodialysis during her hospital stay. So this is the content. Am I moving to the next slide, ma'am?
Yes, it is
Yes. Just
visible,
keep
I think.
moving. We'll stop you when you want.
It's moving, right, ma'am? Okay. So the contents to my case study, introduction, pathophysiology, diagnostic criteria, etiology, signs and symptoms, management, and coming to case study. So introduction, what is this preeclampsia? It is characterized by a new onset of hypertension, typically accompanied by proteinuria, and it normally develops after 20 weeks of gestation and often close to the term. This condition is a spectrum of the hypertensive disease in pregnancy patient, starting with the gestational hypertension and develop into increasingly severe features before it reach to the most severe symptoms like eclampsia and HELLP syndrome. So the pathophysiology, like the causes to this preeclampsia is unknown, but some genetic factors, pre-existing factors, and immunological factors might lead to this preeclampsia, which leads to the shallow of the placentation and reduce the placental perfusion, which leads to the intrauterine growth restriction. This will preeclampsia will circulate the anti-angiotensin in the blood vessel in the circulation of the mother and leads to the decrease in the placental growth factor and vascular endothelial growth factor, and then which other factors also includes obesity, pro-inflammatory factors, and auto antibodies, which can lead to the endothelial dysfunction, capillary leak, and vasospasm, which can lead to proteinuria, glomerular endotheliosis, preeclampsia, coagulation, HELLP syndrome, eclampsia, angiotensin sensitivity, and hypertension. Next comes the diagnostic criteria. Systolic blood pressure of more than 160 mmHg or diastolic blood pressure of less than of more than 110 mmHg, thrombocytopenia, renal insufficiency like serum increased level of serum creatinine, new onset of headache, visual disturbances, pulmonary edema, and impaired liver functions. So what are the complications of preeclampsia? In maternal, it can leads to the complication to central nervous system, which can cause seizures, cerebral edema, cerebral hemorrhage, stroke, hepatic failure, hepatic rupture, subcascular hemorrhage, to pulmonary edema, renal failure, eclampsia, and HELLP syndrome. And the complication of preeclampsia for the fetal, it leads to preterm delivery, stillbirth, placental abruption, uteroplacental insufficiency. So the etiology, the precise mechanism for the development of this preeclampsia is unknown. However, it is believed to result from an interplay of genetic, immunological, and environmental factors, leading to abnormal placentation, immune maladaptation, system endothelial dysfunction, genetic and epigenetic factors, renin, angiotensin, aldosterone system, metabolic and lifestyle factors, oxidative stress, maternal risk factor, paternal factors, and environmental and socio-demographic factors. Coming to the signs and symptoms, signs: abnormal weight gain, raised blood pressure, edema, pulmonary edema, protein in urine, low or lessened output of urine, and vaginal bleeding. And the symptoms includes headache, nausea or vomiting, pain in the belly, vision changes, and feeling the baby move less than usual. So, who's at most risk for this preeclampsia? Primigravida, those a mother who is experienced first-time pregnancy, family history, placental abnormalities, obesity, pre-existing vascular disease, pregnant with twins or triplets or more, thrombophilias. So the prevalence for this preeclampsia is contributing to maternal and fetal morbidity and mortality worldwide. Globally, it affects approximately 5 to 7% of all the pregnancies. It is a significant concern in India with reported prevalence rates varying across studies and regions. The incidence of preeclampsia in India is reported to be 8 to 10% of the pregnancy, according to IEOG. So the management for this disease, preeclampsia disorder, the primary treatment for preeclampsia is either to deliver the baby or manage the condition until the best time to deliver the baby. Management of preeclampsia begins with early diagnosis and intervention, focusing on adequate blood pressure and control the seizure prevention. Coming to my case presentation, patient's profile, a 31-year-old female, Mrs. B, came with complaints of labor pain and was found to have high BP during her when she was admitted in the hospital with 160 to 100 mmHg BP. Patient was a known case of chronic kidney disease with one unsuccessful pregnancy due to abruption placentae and 3 abortions in view of CKD medical management before her first pregnancy, first successful pregnancy. And now she came again with another pregnancy. So the clinical findings was that she was on dialysis 4 years back, but only for 2 months. And on her last prenatal checkup, that is on her 34 weeks, the patient was found to have BP with 145 to 96 mmHg associated with proteinuria, and her estimated filtration glomerular rate with only 14 ml per minute per 1.7 m squared, and her urine protein creatinine ratio is 1.87, and her kidney biopsy shows Apache acute cortical necrosis, and her ultrasound shows a fetal with intrauterine growth restriction, 4th percentile. Patient was diagnosed with preeclampsia. So this is her course in the hospital. In her first day, the patient was admitted and was taken up for emergency LSCS in view of her 6-time pregnancy and G6P1L1A4 at term gestation with preeclampsia and fetal growth restriction and a known case of CKD. She delivered a baby weight 2.12 kg. Post-operation, she was shifted to SICU for renal replacement therapy and was treated with antibiotics and analgesics and other supportive care. Patient was on dialysis. On her second day, patient was hemodynamically stable and tolerating renal diet and was shifted to wards. Due to her low HB level, patient was giving injection Ferinject 500 mg through IV. On her third day of her hospital stay, patient HB level was still low. Injection Crepsin and injection Ferinject was given. Patient tolerates diet well. Patient was encouraged for breastfeeding the baby. And on her fourth day, which is the last day, patient underwent a second dialysis and patient was doing well. Hence, she got discharged. So comes to the nutrition assessment, the anthropometric measurement, her height was 162, weight during her pregnancy was 73, her usual weight was 69, and her BMI was 26, which falls under the category of overweight, and her ideal body weight was 62. And the dietary assessment, the type of diet was renal diet, meal pattern was 3 to 4, mode of feeding was oral, food dislike, she does not have any allergic to milk, but she don't like to drink milk. So her food habit is a non-vegetarian. Her dietary intake at home was normal, and her activity level was moderate active. So these are the biochemical assessment during her stay in this hospital. Her hemoglobin was seen to be very low, and her RBC also was low. PEG cell volume also was low, and her renal function test also seems to be deranged. Sodium was on a lower side, potassium was high on her first day, creatinine was high on all the stays, on all her stay in the hospital. Even the urea and uric acid also was seen to be very high during her stay in this hospital. So these are the other investigation: our blood pressure, pulse rate, respiration, temperature, and SpO2 during her stay in this hospital. Next come the medication. These are the medicines that have been used during her stay in this hospital: injection Magnex Fort, injection Pan, injection Amset, Paracet, Fragmin, Carnisure, injection Dabra, injection Nervigen plus Pharynject, Perfalgan, injection Optineuron, Sporolac, Tap Aldo, Casidol, Tap Nodosis, Tap Shelcal, Tap Chimorac, Tap Deslor, Tap Ceftum, Tap Rocaltrol. Next comes to the PES statement. So the problem was labor pain, and at that time she was 36 weeks at term gestation. Etiology, the pre-existing chronic kidney disease and endothelial dysfunction. Signs and symptom, persistent hypertension, which is more than 140 to 90 by 90 mmHg. So this is her 24-hour dietary recall, what she had before she was admitted in hospital. And her total intake. So this is the nutrition calculation for her 24 dietary recall. Her energy intake was 1548.62 calories. Carbohydrate was 185.05, which is 48% from the total calories. Protein was 58.55 grams. Fats was 60.14 grams, which is 35 grams from the total calories. Sodium was 189.44, and potassium was 2566.75 mg. So the interpretation for the 24-hour dietary recall: patient was eating a normally South Indian food. Patient was seen to consume less calories with regard to her third trimester, and patients denies of having any less appetite. So these are the food frequency: cereals, whole grams daily, green leafy vegetables weekly, roots and tubers she used to have daily, other vegetable fruits weekly, fats and oil, milk products daily, milk products like curd and all she used to have paneer but not milk, animal product weekly, outside food rarely, papat pickles monthly, and beverage and juices weekly. So the hospital case progression during her stay here, on when she came, she was keeping on Nilpa oral because of her LSCS, and then patient started on clear liquid diet, renal clear liquid diet on at 4 p.m. And on the next coming days, 10th, 11th, and 12th, she was on a renal soft diet. So when she was on a liquid diet at 4 p.m., dal soup was given because since her potassium was high, so we did not suggest her to have any fruit juices or tender coconut water, but a clear dal soup was given. And 6 p.m. she was having a full liquid diet, which we have given rice ganji, and then patient started on soft diet at dinner. So this is the hospital dietary recall: small and frequent meals throughout the day. And the nutrition calculation for the hospital dietary recall: the energy was 16.98 kilocalories, carbohydrate was 228.11 gram, protein was 79.06 gram, fats was 60.74 grams, sodium 284.01 mg, potassium was 3576.22 mg. So the type of diet that was provided to her was renal diet, Frequency of meals, 6 small frequency meals, and consistency of diet is soft diet. So the nutrition intervention energy, 25 to 30 kilocalories per kg body weight is recommended to prevent malnutrition, to support fetal growth, and to meet the increased metabolic demands. An additional 450 to 500 kilocalories per day is required during lactation. Protein, 1 gram per kg body weight plus 17.6 gram of protein is recommended to support maternal and fetal needs. Fats, essential fatty acids, are crucial for the infant brain development. Omega-3 rich foods like flax seeds and walnuts should be encouraged. Carbohydrates, a minimum of 201 gram per day to support lactation and prevent ketosis. Sodium management, limit sodium to 1500 to 2000 mg per day to control blood pressure and reduce edema. Potassium control, limit potassium intake to 3500 mg per day to prevent hyperkalemia. And the micronutrients, iron, 30 mg of iron is recommended to prevent anemia. Folate, 600 mcg per day for fetal neurodevelopment. Calcium and vitamin D, 100 mg per day and 600 IU per day to support bone health and support calcium absorption. So the prescribed diet energy is 2,325 calories, which I have calculated 25 kilocalories per kg body weight plus extra 600 kilocalories as per the RDA for lactation. And the proteins was 1 gram per day per kg body weight plus 17.6 gram as per RDA was recommended for the patient. So this is the prescribed diet. Small and frequent meals was prescribed throughout the day for her. And the total intake of the total calories for the prescribed diet, it comes to 1992.56 calories, 258.75 carbohydrates, 87.97 protein, 62.87 fats, 283.49 grams of mg of sodium, and 301.38.72 mg of potassium. So the exchange list of the prescribed diet plan, 9 exchange of cereal was given throughout the whole day, 3 exchange of whole grams and pulses, 2 exchange of fruits and tubers, 3 exchange of other vegetables, 1 exchange of fruits, 5 exchange of fats and oils, 3 exchange of milk products, 3 exchange of animal products and eggs, and 2 exchange of sugar. So this is the portion size distribution of the menu plan. So coming to the discharge advice, to eat small quantities and at frequent intervals, reduce the consumption of salt used in cooking, to avoid refined cereals like maida, and do not add soda or baking powder to any kinds of foods or cooking. Inclusion of white meat like skinless chicken, fish, and egg white preparation like omelette, boiled egg, etc. Always read the label of the food products to check the sodium, potassium, and phosphorus content. To avoid consumption of packet food items of outside foods, deep fried foods, etc. Instead of deep frying your foods, try to bake, boil, or steam when preparing foods. 10 to 15 minutes walking is recommended after every meal. So in here are some of the galactogogues rich foods which helps in milk secretion for the lactating mother. And foods that needs to be avoided are millets and its product, tender coconut water and coconut gravies, fruit juices, aerated drinks, packet beverages, deep fried bakery products, mixture, buns, puff, etc. Red meat, egg yolk, prawns, beef, pork, mutton, organ meats like brain, liver, kidney, preserved foods like sauce, cheese, ready-made soups, pickles, papa, chutneys, and extra salt on the table. Remove cream from milk, curd, buttermilk, and skin from chicken. Avoid consuming green leafy vegetable. All these are foods have been recommended to her to be avoided. So the follow-up, the patient was reviewed after 2 weeks from discharge and was following the recommended diet plan. On her first follow-up, her appetite and bowel movement was normal. Patient was having 2 times egg white per day. Her BP was normal. Patient continues breastfed the baby. And on her second follow-up, patient intake was normal. So the same energy requirement was encouraged for the patient. Patient-related queries were resolved and patient continues to breastfeed the baby. So these are the reference. Thank you. Hello, ma'am.
Yeah, sorry, I could not get the mic. Okay. Daphnia,
Yes, ma'am.
hi. So first of all, who named you Daphnia?
Yes, ma'am.
Who named you Daphnia?
Yes, my full name is Daphnia, ma'am.
My name is Daphne, so I'm wondering who gave you also the name Daphnia.
My dad, my dad
Okay.
gave me.
Oh, great. My dad too. Okay. Okay. Now, Daphnia, see,
Yes, ma'am.
you have not calculated salt anywhere for this patient. How much was she using at home?
We have recommended salt intake should be less than
No,
3
no, no.
grams per day, ma'am.
At home, in her home diet, did she use any salt?
She, the prescribed diet, ma'am.
Home
No, no,
The
no.
recall.
one, yeah,
Daphnia, what ma'am is asking is, since she is a case of preeclampsia, she came with,
yes, ma'am.
very bad kidney repercussions. So ma'am is asking
Yes,
you,
ma'am.
have you calculated her salt intake while you're calculating her home recall? Am I right,
No,
ma'am?
ma'am. I
You're
have not.
asking this
Yes,
to
yes.
you?
That's what I mean. That's what I
No,
mean.
ma'am.
Yeah. Yeah.
Yeah,
Okay.
she
So
was taken.
just ask her that, or you should have asked her that and calculated her salt intake also.
Fluids also, ma'am.
Yes,
Yeah.
Fluid also nowhere it's calculated, prescribed. Was there any restriction? Nothing is
Mm.
mentioned.
Though it's a renal, she came in with problems.
Hmm. And was she
Okay.
on dialysis post discharge also?
no, ma'am. She was on dialysis only during her hospital stay, and after discharge, she's not on dialysis, ma'am.
But protein, don't you think it's too much if you're giving 80 grams of protein for a
80
patient who
grams.
on discharge was her creatinine was 4? So 80 is,
Yes,
I think, too much.
as per the renal team that we have spoken, ma'am, they actually we used to give 1.2 grams for dialysis, but the renal team was saying that you can give 1 gram of protein plus with the RDA extra protein for the patient.
This was recommended there, is it? Okay. And
Yes.
this potassium, normal is 3,500. You've said that low is 3,500 in your recommendations. Go to your potassium wherever you've mentioned.
This one, ma'am? Oh, no, no. This
Yeah, here.
hospital recall
No, no,
pricing.
not hospital recall. Wherever you've given your recommendations, you've given low
Recommended,
potassium
your
diet of
recommended diet.
3,500, but normal is 3,500, no?
In here, ma'am. This potassium
In your
control, ma'am.
calculation, Daphnia,
In calculation also it's 3,500 and your recommended also is 3,500. But that is normal, not low.
yeah, for a kidney patient, even though it's a
Yes.
temporary phase, how
And
low should
you've,
you prescribe?
yes. And you've mentioned nuts over here. Nuts are high in potassium in
Yeah.
your
Yeah.
recommendation again.
Yeah.
And your, ma'am, even the previous case study, I couldn't chat in the previous one. Both their PES statements are wrong.
It was very elaborate.
No, no, not elaborate. They're going by medical diagnosis, not by nutritional diagnosis. She has also
Nutritional
mentioned
diet.
giddiness. This
Yes,
one
yes.
also has mentioned pregnancy.
I
So
was
it's
going to
not
tell them that
inadequate
as a,
mental
yeah,
intake. Yeah,
that's
or
true.
growth rate lower than expected for this one. So they've not gone through the PES book. Apollo itself, ma'am,
Aishwarya,
Sandhya ma'am.
Aishwarya, are you there?
Yes, yes. You're
So,
right, Anisha.
ma'am, your
Aishwarya,
Apollo had come out with one update, no, ma'am. PES statement, one book only was there. No, that has a very beautiful thing. The whole thing is there in
We
that.
have the
I
manual
think
here.
all,
it's just
yeah.
one sentence. It's just one sentence.
So it should be growth rate below expected as evidenced by your elevated enzymes or elevated creatinine.
Something. Yeah.
Yeah,
Okay, ma'am.
and related to whatever, and as evidenced by if she had any edema or her blood parameters will come over there. This is
Yes,
pregnancy
ma'am.
can't be a problem. It's not a nutritional diagnosis.
When I saw
Okay,
the
ma'am.
slide with you, and I was shocked because every
Even
time
in
we
the
have
previous
presentation,
even in the
we
previous
said
one, the pest said problem said giddiness. It's decreased
yes,
nutrient intake or mineral intake or anything.
Yeah.
yes,
It's not just giddiness.
and the etiology was low vitamin B12 levels, and she is
Yeah,
presenting for anemia.
yeah. So pest should be nutritional diagnosis, then etiology, and two signs and symptoms. So I don't know.
Yes.
I think we
Okay,
should take
ma'am.
a class on pest for everyone.
Yes,
Yeah.
every time we will have a discussion on that,
Yeah.
elaborate, and still, these mistakes even I encountered.
Hmm.
Aishwarya, you're
Okay, ma'am, from my
listening?
end.
Aishwarya, are you also there?
She's on the
Yes, ma'am.
backstage, I think.
Okay, okay. Anyway,
Please come on the stage.
yeah. And Aishwarya also, I wanted to tell her one more thing afterwards. Can you hear Aishwarya? Can they hear Sandhya what we say?
Yes,
Yes,
ma'am, I can
ma'am.
hear you.
Okay. Yeah, no, no, no. I'm saying, can Aishwarya hear now what I'm saying?
Yes,
Yeah,
yes,
ma'am,
she's
I can
on the
hear.
stage
Ah,
now.
okay. So, Aishwarya, even for anemia, you had not calculated vitamin C. It should
Uh,
balance somewhere.
yeah, it is calculated, ma'am.
Was it?
Yeah, ma'am. In prescribed that it is calculated.
Sorry, sorry. Okay, okay. I just thought of it
Oh,
afterwards.
ma'am,
Okay,
if
ma'am.
Aishwarya is there, I have a few things for her also. Um, I couldn't actually. I sent a message, but I don't think it went. So ideal body weight was wrong, 76. Then
Gratitude and
calories
Aishwarya, you all
is
can switch on the camera since it's a discussion.
Ma'am,
okay. Aishwarya, your calories per kg. He was how old? 20 something, no?
21,
14.
21.
Yeah. For the anemia patient, he was only 21,
Ah,
and 21 calories per kg is too low. So that we give for obese patients, not overweight. And he was barely 5 kgs overweight according
yeah.
to your ideal
No,
body
her
weight.
whole calculation was wrong, Anisha.
Yeah.
Yeah.
Huh. And again, you've given 1600 as his ideal intake. Again, if you're going by 21, it's right. But again, too low calories, too low.
Hmm.
21 is given, ma'am. 21 calories given.
Yes, but for a
No,
21-year-old, it's too low,
21 is wrong, we're
is what I'm
saying. There
saying.
is no guideline for
Okay, we need
21.
to. So, what is the normal calorie per kg that you give? Normal.
Normal, we suggest 25 to 30 calorie.
Obese?
Obese, uh, it will comes to according to the ideal body weight we used to give.
Okay, per calories per kg, how much for obese?
20, 23 to 25.
Mm. So, for overweight, you have given 21.
Yes, ma'am. Then if I'm giving 22, 23 and all, it was coming so high value.
That's okay. He's only 21 years old. His metabolism isn't as low as a 40-year-old. No, can still
Okay.
go. Right? So, it's too low. You need to increase it. Give at least 25 or 28. 21 is too low.
Okay.
See,
35 is
Aishwarya,
You
normal.
can use anything.
you must have something to back your 21 or your 23. If Sri Lakshmi or some textbook says, or NIN says, ICMR says, go by that.
Okay.
Have a backup for what you are calculating. Go by the RDA and multiply
You
by
have to
what you're
give a
supposed to
reference.
do. Okay.
Always give a
Yeah.
reference. What is the reference that you've taken into consideration? When you're giving
Okay.
reference, these kind of mistakes will not happen. When
Okay.
you read
Okay.
up, no, you will do the correction then and there itself.
Or you need to convince us that 21 calories is good enough.
Yeah,
Yeah.
that's what.
No.
If I'm giving
Yeah.
20,
Either reference or convince.
if I am giving 25 calorie, it is coming around 1900.
That's okay. Like I said, he's only 20. What does he do? He's studying.
He study, and he
Ah,
is
so
not
he'll be still
that
active
doing
only,
any
na?
exercise or like not any other physical activity he was not doing. That's why
No,
Are
I
you
see,
recommending physical activity?
Aishwarya, like I'm saying, why can't you give 22.2 or 21.8?
Ma'am,
Wait.
she's gone by hospital recall
Yes,
calories
yes.
per kg, I think.
Yeah. No, Anisha, they do it ulta, these students. They work out the calorie first and then they work out how much it's breaking down to.
Yeah, exactly. And whatever
That's correct,
average she's
ma'am. What you're
gotten by
saying is
3 days,
absolutely right.
yeah,
Yeah.
they don't go by activity and
So
age and
have
everything.
have a guideline and multiply by that. Have a standard. Okay. Okay. Defina, you can go on with your next small bowel
Okay, ma'am.
obstruction.
Okay, ma'am. Okay, so my next presentation is small bowel obstruction. Introduction. The small bowel obstruction is a blockage in the small intestine that prevents the normal movement of food, fluids, and gas through the digestive tract, which can lead to symptoms such as abdominal pain, vomiting, bloating, and constipation. So, what are the classification of small bowel obstruction? The functional, this functional classification is dysfunction of the peristalsis of the stomach, mechanical caused by intraluminal or extraluminal mechanical compression. The common causes are adhesion, hernias, malignancies, infections, and inflammatory disorder. So the partial and complete small bowel obstruction, like hernias, uh, the complete results the intestinal ischemia, leading to intestinal necrosis and perforation. Example like a closed loop obstruction. So the pathophysiology for the small bowel obstruction, it can cause mechanically obstruction, can cause by intrinsic luminal obstruction or extrinsic compression of small intestine, progressive dilation of small intestine proximal to blockage. Distal to blockage, bowel decompressed as luminal content fast, air and gas, bacterial fermentation causing bowel distension, progressive continues to edematous bowel wall, loss of normal absorptive function, fluid sequestered into bowel lumen. The ischemic necrosis, commonly caused by twisting of the intestine, mesentery around adhesive band, intestinal attachment. Ischemia increased with closed loop obstruction, and if bowel
Defina,
dilate,
you can skip these
extensive.
kind of things. Defina,
Yes, ma'am.
skip these
Yes,
kind of
ma'am.
things, okay? Skip these
Okay.
kind of slides. Just tell us in a few sentences, but focus on the important parts, okay?
Okay, ma'am. So I'll come to the etiology. So what are the causes for this small bowel obstruction? It can causes by adhesion, tumors, or complicated hernias, and other causes like Crohn's disease, gallstones, volvulus, or intersusception. And the symptoms for the small bowel obstruction are abdominal pain, colic or sharp, vomiting, abdominal distension, constipation, and dehydration. So the diagnosis for this small bowel obstruction can be done by abdominal X-ray, CT scan, and ultrasound, and some laboratory test. Treatment option can conservative measure treatment like nasogastric tube for decompression, IV fluid for electrolytes for dehydration. Surgical treatment like laparotomy or laparoscopy can be done. So the complication for untreated bowel obstruction can lead to perforation, sepsis, ischemia, and long-term digestive issues. So come to the case study. The clinical assessment. Patient came with complaints of abdominal pain since 2 weeks, insidious onsets and progressive in nature, also with multiple episodes of vomiting. Past complaint, patient was a known case of CA cervix status post radiotherapy 15 years ago. So the provisional diagnosis was small bowel obstruction with enterocutaneous fistula. Her past surgery, status post of hysterectomy 15 years ago, and laparoscopy, adhesiolysis, ileal stricture resection, and end-to-end anastomosis on the 7, just 2 weeks before she was admitted. This surgery was done. So her current surgery, which was done during her stay in this hospital, was exploratory laparotomy, resection and anastomosis, stoma formation, and cholecystectomy. Comorbidities, she's having hypothyroidism and hypertension. So the patient's profile, her age is 51, female. She's from Karnataka, and the date of admission was 27 on the 9th, 24. Date of discharge 10, and the length of days was 14 days. Her anthropometric measurement, her height was 158, weight was 60 kgs, body mass 24, which falls under the normal range, and her ideal body weight is 58. So next comes to the biochemical assessment. Her CBC, RFT were all in a normal range. So these are the other investigation during her stay: the blood pressure, pulse rate, respiration, temperature, and SpO2. These are the courses of medication in her during her stay in this hospital. So next comes the dietary assessment. The type of diet was low salt diet. Meal pattern during her when she was having a liquid diet, every second hourly liquid diet was provided, and when she was having a soft diet, 4 to 5 meals pattern was provided, and mode of feeding was oral. Food allergy, she does not have any food allergy, and she's a non-vegetarian. So the past statement: problems was abdominal pain, loss of appetite, and not past motion. The etiology was addition because of the recent surgery, perforation in ileum, bile leak, and a mass cocoon formed by the ileal bowel duct. Symptoms was hypertension, multiple vomiting, and colicky bowel sound and distension. So her 24-hour dietary recall, the nutrition calculation for her 24-hour dietary recall is that she's having her energy was only 630.86 calories, carbohydrate was 95, protein was 28 grams, fats was 31, and sodium was 177 mg. The interpretation for this the 24-hour dietary home recall was that she's having a normal South Indian food, but the recall says that the patients consume very less intake due to her low appetite, and the consumption of fruits also is negligible. So these are the food frequency: cereals, pulses, vegetables she used to consume daily, fruits monthly, animal products, papa pickles weekly, charts, beverage, outside food, all those monthly, and rarely she used to have. So this is the case progression. 3 days she was on Nilpa oral, and then she started on soft diet. And then on the day 6, she was Nilpa oral again, clear liquid. And the day 8, she did her surgery, and she was on NPO for 2 days and started on clear liquid, full liquid, and then slowly progressed to low soft diet. And on the day 14, soft diet was provided because her sodium was a little low, so soft diet was provided. This is the hospital dietary recall: clear liquid diet. During her intake of clear liquid diet, every second hourly clear liquid diet was provided, 150 ml per hour. So the energy comes to 375.7 kilocalories, and proteins 5.42 grams. So this is the hospital recall diet. A low salt diet was provided to her, small and frequent meals throughout the day, and her intake was 1269.83 calories of energy during her hospital stay, 166.27 grams of carbohydrates, 49.71 grams of proteins, 47.25 grams of fats, and 207.23 of sodium. So the diet prescription was energy was given 15 calories, that is 25 kilocalories per kg body weight, and protein was given 60 gram, which is 1 gram per kg body weight. So the medical nutrition therapy was, the goal is to maintain optimal nutrition status to support the gut health, reduce malabsorption, manage symptoms, and support recovery. The nutritional assessment is to evaluate the nutritional status, assess the gut function and motility, identify the malabsorption patterns, and monitor laboratory values. The nutrition intervention is to consider parenteral nutrition if the obstruction is complete or if the patient has severe malabsorption, to consider enteral nutrition if the obstruction is partial or if the patient has some gut function, to recommend a low residue diet to reduce fiber and intake and minimize gut stimulation, electrolyte and mineral supplements to prevent deficiency and support gut health. Protein is to ensure adequate protein intake and to support the gut health and prevent malabsorption. Fats to reduce malabsorption. Carbohydrates, refined complex carbohydrate to reduce malabsorption and support gut health. So these are the exchange list of the diet plan: 6 exchange of cereals, 2 exchange of whole grams and pulses, 3 to 4 exchange of vegetables, 2 exchange of fruits, 5 exchange of milk, 3 exchange of oil, of fats, 1.5 exchange of animal products, and sugars to exchange. So this is the sample menu of the discharge diet plan. A low residue diet, low salt and low residue diet plan was recommended for the patient. And this is the discharge diet plan. Small and frequent meals was recommended throughout the day, and the total intake, the total of the prescribed diet was 1535.3 kilocalories, 200.19 grams of carbohydrates, 61.89 grams of protein, 50.47 grams of fats, and 163.61 mg of sodium. So the discharge diet advice is to have a small and frequent meals pattern throughout the day, avoid spicy and oily deep fried foods, to avoid foods which feels like it's irritating the stomach like bloating, heartburn, etc. Limit salt intake to 3 to 4 grams and fat to 15 grams per day. To prefer consuming more of vegetable oil than coconut and groundnut oil. Try including fruits, skin out in your daily meals in the form of milkshake or juice. Avoid having a high fiber diet to prevent blockage and other issues. A high protein diet is recommended for better wound recovery. Engage in a simple physical activity like walking, practice stress medication like deep breathing, and maintain a healthy sleep habit. So, in our follow up, the patient was reviewed after 15 days from the discharge and was following the recommended diet plan. And on the first follow up, dietary pattern was improved and patient was having small and frequent meal as advised. Patient started to include skin out fruits either in the form of smoothies or milkshake as recommended. Patient bowel movement is good and she had to change a 6 to 5 stomach bag. Her BP level was in control and little physical activity was done on the first, second week of her surgery. And on the next follow up, patient intake was good. Patient queries regarding food intake was resolved. And these are the reference. Thank you.
Just a minute.
Hello,
Thank you.
ma'am.
Yeah. So, Defina,
Yes, ma'am.
even for your previous case, I think you
Yes,
must
ma'am.
physically go and weigh 3 grams of mustard seed and you see if you need it for one meal.
Okay, ma'am.
Okay. It's almost
Okay,
half a teaspoon. You just go and do that exercise. Okay. That's one thing.
yes,
And then for this obstruction, don't you need to suggest a little more of fluids or see in your prescribed diet also? It's just a normal diet.
yes, ma'am.
Some more buttermilk, waters, infused waters, juices. You have said
Yes, ma'am.
fruit extra somewhere, but in the form of fluids, please increase as much as you can.
Vegetables. Yes, ma'am. Yes.
Okay, fruit you have.
Yes. I have in mid morning. I have added vegetable soup, ma'am.
That's all.
So, yeah, it's yes, ma'am.
Okay,
In
More
recommendations,
hydration.
fluids is not there also.
yeah. And coffee, you can't, for this kind of a patient, not to start the day with coffee, no? So just see your liquids and see what you have suggested. Make suitable
Yes, ma'am.
changes. Okay.
Yes, ma'am.
Include
Sure,
And
fluids
I
as
will
in
much
take
as
the
that.
you can.
Yes, ma'am.
Include fluids as much as you can.
Yes, ma'am.
and
Yes.
in the
Okay.
interventions, why have you mentioned parenteral and enteral nutrition? This patient was on oral diet only. You've gone
Yeah,
by
I
it
think
was
general
you're giving
guidelines. For this
general.
particular, yeah, for this particular patient, whatever intervention is needed, you need to mention only that.
okay, ma'am. I was doing in
Okay.
general, ma'am. That is why. Okay, ma'am.
Yeah.
I will make the
And
changes.
one more thing, your PES again should be altered GI function.
Yes, ma'am. Yes,
Okay.
ma'am. I will make the changes. Yes, ma'am.
Mm. Yeah. From my end, these three things.
3 gram seeds. Yeah. Okay.
Yes, ma'am.
Okay. Thank you, Delphina.
Okay. Thank you so much, ma'am.
Welcome. Welcome. Okay. Yeah, that's all. Arsnana, you're there? Arsala?
Yes, ma'am, I'm here. I'll start.
Okay. Yes.
Yeah, she's there, ma'am.
So, good afternoon, everyone. Myself, Arsala. I have done my RD internship at Apollo Hospital, Bannerghatta, under the guidance of Dr. Sandhya, ma'am. Thank you, ma'am, for giving me this opportunity. So, today I'm going to present my case study on chronic liver disease and bariatric surgery. Coming to chronic liver disease, it's a range of progressive liver condition that causes gradual damage to the liver. It can result from various causes such as infection, toxin, genetic disorders, lifestyle modification. Coming to signs and symptoms, fatigue, anorexia, weight loss, abdominal pain, jaundice, dark colored urine. Coming to complications, ascites, hepatic encephalopathy, and malnutrition. So, diagnostic test, a group of blood tests known as liver functioning test can diagnose liver disease through imaging techniques like ultrasound, CT, and MRI, and checking a tissue sample. Coming to the treatment, our goal is to to stop the progression of the disease and complication. It requires a multidisciplinary approach. Coming to case study, basically patient came with a complaint of abdominal distension since a week, and there was an onset gradual progressive of the abdominal pain and discomfort in the sitting position. Past medical history, the patient was diagnosed with dengue with thrombocytopenia past 1.5 months. Coming to provisional diagnosis, chronic liver disease with portal hypertension. So coming to his demographic data, he was 39-year-old male. These are the anthropometric measurements where height was 168 centimeter, weight was 73.6 kgs, BMI was 26.07 kg per meter square. He falls under the category of overweight. His ideal body weight was 68 kgs and usual body weight is 70. These were the biochemical assessments done where there was D range of blood urea, hemoglobin, and platelet. This was the medication given during the time of the hospital stay: injection Nervizen Plus, injection Magneforte, injection vitamin K, tab hypodrin, tab diatrol plus, tab
That's okay.
termin
Just
A.
skip this. Skip this slide. We know,
Sorry.
meaning it's okay. Yeah.
So these are the medication given advised during the discharge time. So coming to the dietary assessment, the type of diet was suggested hepatic diet, number of meals 3 to 4 meals per day. Mode of feeding was oral. Coming to his food habit, the patient preferred taking non-veg. He was from South India. And coming to his food habits, the patient was taking excessive intake of red meat, high sodium content food. Coming to pest statement, problem, abdominal pain, fatigue, etiology due to anemia and ascites, signs and symptoms were pedal edema. So coming to his 24-hour recall, the patient usually preferred a South Indian. So these are his preferences, like 24-hour recall, through which 1,468 kilocalories, 243 grams of carbohydrate, 51.03 grams of protein, fat 33.8, and sodium is 254 mg. Coming to food frequency, cereal, pulses, other vegetables, fats and oils, and milk products was taken on a daily basis, while green leaf vegetables, fruits, sugar and Indian sweets, and meat and poultry was taken on a weekly basis. Coming to our nutritional goal, to maintain optimal weight, support healthy liver, limit high sodium content, engage in regular physical activity, increase protein in the diet, manage signs and symptoms, lifestyle modification is a must through healthy sleeping pattern, and manage stress through relaxation techniques like yoga, medication, monitoring, and follow up. Coming to case progression, the hospital stay was 4 days. So this is his 24-hour hospital diet recall. Calories coming up to 1,329, carbohydrate 166.5, protein 45.23 grams, fat 30, and sodium 333.34 mg. Coming to the diet prescription, 25 kilocalories per kg usual body weight, that is 70 was his usual body weight without ascites. So 1700 kilocalories is suggested. Carbohydrate 233 grams, that is 55 percentage from the total calories. Protein was 1.2 grams per kg usual body weight, that is 84 grams. Fat 25% from the total calories. This is a sample menu for the discharge diet plan. food exchange list of the discharge diet plan, where calories were meeting up to 1771 and protein 83.8 grams. Patient was on ONS, that is oral nutrition supplement, where he was taking weekly thrice. So calories like 227 kilocalories were coming from that, and protein about 20 grams. So this is the discharge diet chart, where calories 1696 kilocalories, carbohydrate 217.21 grams, protein 72.12 grams, fat 46.2, sodium 346.7 mg. Coming to the discharge diet advice, so we had recommended him to take small and frequent meals throughout the day, achieve and maintain appropriate body weight, and promote regular physical activity, include more of complex carbohydrates instead of refined maida, then limit salt intake and avoid sugar, outside and processed foods. Since a high protein diet is recommended, adequate amount of fluid is recommended to prevent from dehydration. And since iron is an important element for the formation of blood, include vegetables, cereal, pulses, dry fruits, etc. And instead of deep frying, patient can offer something like for shallow frying, grilling, baked methods of cooking. Promote healthy lifestyle habits while considering and preserving social, cultural, and physiological well-being. Maintain healthy sleep pattern. Maintain the electrolytes and LFT levels. So coming to the follow up was done twice on 17th and 22nd through telephonic. A dietary pattern was improved and was having small and frequent meal as advised, and the abdominal pain was slightly increased during the first follow up. Coming to the second follow up, the patient was following a high protein diet, iron rich diet as advised by us, and the complaints of fatigue and abdominal pain was reduced. These are my references. Thank you.
Okay. I'm just asking you a question. What is your cutoff for being overweight? What is the
Ma'am,
cutoff? What is the BMI cutoff for overweight?
26, like um according to classification
20?
26, ma'am.
Above 26? Below 26? At 26? What is it?
uh,
It's a
Ma'am,
range.
25, like 25 to 29.9 is overweight.
Okay. Which reference is that? What cutoff are you all using?
uh, WHO, ma'am.
Check WHO for Asians.
Okay,
23
ma'am.
is our cutoff. 23 to 25 is overweight.
Overweight.
Okay, so
Okay, I'll
use
check.
that as the new cutoff. So
Okay, ma'am.
actually, this
Sure, ma'am.
you have to evaluate this patient.
Sure, ma'am. Sure.
Okay, and
Yes, ma'am.
then
I'll do that.
see in the diet recall, you are not asking for oil and salt intake. This patient definitely you're controlling the salt now when prescribing the
Huh.
diet. Even for the previous ones, I told her also preeclampsia and all. You are sending them off on a low salt diet, but what is their salt intake? You are calculating the sodium, but what is the
Yes, ma'am.
salt
Yes.
intake? What is the salt you are suggesting? Should they add any table salt? Should they add 1 gram? Should they add 2 grams? Should they not add at all?
Ma'am,
Okay,
usually one, like, yes, ma'am.
tell me. Usually,
She's not
I'll make,
calculated salt at all, ma'am. Even
that's
in the
what. So
phone
what are you
record.
saying? Usually,
ma'am, usually less than 2.5 gram of salt, like we restrict, not more than that.
salt. Okay, that is salt. So how much have you got in the salt in the sodium here in her diet?
Here in 24-hour recall, we have got 333.34 mg, ma'am.
So how much salt can she have?
Another 1.5 grams she can take, ma'am.
Grams of salt or sodium?
Salt, like she can add, ma'am. He can add.
So work that out. Go back, look at your textbooks
Yes,
and see how much she can have. How much of
sure, ma'am.
salt? And already so much of sodium is here. Remember, only 40 mg you have to convert. So
Okay, ma'am.
look at the calculation and you see how much of salt you can allow this patient now when she goes home.
Okay.
Was the patient
Okay.
taking salt free in the hospital?
Ma'am,
No
we
Low
salt
had
for
salt
some.
or
taken
salt free?
low salt,
Low
low
salt
salt.
for some.
So sodium is not calculated from the table salt at all at home and in the hospital.
Ah, that's what I'm asking.
It's
Okay, so
not
you calculate
calculated.
that and write it down somewhere.
Hmm.
Sure, ma'am. I'll do that.
Okay.
And was he not taking alcohol?
No, ma'am.
You asked, that question was asked. How about fluids?
Yes, ma'am. I asked. I
Did
asked.
he have fluid restriction in the hospital?
To restriction, it was like 1.5 liters to 2, ma'am.
You've not
Doctor have
mentioned
written.
that anywhere.
Okay.
And at home also, was he restricting his fluids before he got admitted?
No, ma'am. Usually his fluid intake was like 2 to 2.5 liters. In hospital, it was 1.5 to 2, ma'am, per
Okay,
day.
that has to be mentioned. And you have to
Sure,
give
ma'am.
normal protein, I think, for CLD, not high protein. 1.2 is too much.
Ah, 1.2, even I saw that.
Yes, it's high biological value protein, but normal, zero point 0.8 to 1 only.
Okay.
Did
Okay,
any
ma'am.
textbook tell you this? 1.2?
Ma'am,
Ma'am,
usually
this
I
is the
went
old
through
one.
research papers, all those things. So high protein diet is usually recommended in CLD. So,
High protein. If
It's
they are saying how much is the high protein, just put it in a bracket here.
like, ma'am, 1.1 to 1.2 to 3 grams was usually suggested there, where I had referred.
But
2
this
to 3
research
grams.
articles also, yeah, research articles also, you have to be careful as to how many subjects they took and is it valid. You can't just pick it up from articles.
Yes, yes.
Textbooks, the latest textbooks would be your ideal choice for
Yeah,
recommendations for all
textbooks.
this.
Yeah, or our
Okay.
NIN, ICMR, these kind of things. Okay.
Ah,
Okay.
and
Okay.
here again, PES you need to change. It's excessive
Sure.
fluid, excessive protein, fat, sodium. You can give so many things, not
Okay.
whatever you've given. Okay.
Okay.
Okay. Continue with your bariatric.
Sure, ma'am. Ma'am, is it visible?
Yes,
Yes,
it's
it is.
visible.
So bariatric surgery, it refers to a range of surgical procedures aimed at
No,
promoting
no,
weight
no. We
loss
can't
in
see
individuals.
bariatric. Sorry, sorry. We can't see bariatric. It's still stuck in the CLD. Let's try again.
Ma'am, now?
No, ma.
Ma'am, I have shared. Now is it visible, ma'am?
No, ma. Wait, we'll try. No.
I'm checking, ma'am. Okay. Ma'am, now?
No. Okay, now it has. Yeah, yeah.
Yes, ma'am. I'll see it. So, bariatric surgery refers to a range of surgical procedure aimed at promoting weight loss in individuals who are severely obese. So, these alters our anatomy of our GI tract to reduce the food intake and nutrient absorption. So, coming to the cause, people who are severely obese or have failed other weight loss methods. Coming to the signs and symptoms indicating for the need of surgery, inability to lose weight, and due to some quality of life is a compromise like difficulty performing walking, climbing stair, or performing some household tasks due to excessive body weight. and social, emotional, or psychological distress, including like feeling of embarrassment, isolation of or a low self-esteem due to excess of weight gain. Coming to the types of bariatric surgery: gastric bypass surgery, sleeve gastrectomy, adjustable gastric band. So this patient had undergone gastric bypass surgery. So the stomach is divided into the upper pouch in which is connected directly to the small intestine by passing a large portion of stomach and small intestine. Basically, surgeon creates a small pouch at the top of your stomach, separating it from the lower portion with the surgical steps. Then they divide your small intestine, bring it to the new segment which connects to the small stomach pouch. Now the food will now flow through that new segment. So surgical complication. So all surgicals involve a certain risk. So coming to the bariatric surgery, a bleeding, infection, a blood clot, hernia, small bowel obstruction, etc. Coming to the case study, a patient came with a complaint of cough related to GERD since 1 month, history of recurrent burning in the chest, nausea and fatigue, obesity with 39.6, evaluated for the same and found out that lacks lower esophageal sphincter. Coming to the past medical history, there was a liposuction done for the patient for breast reduction. Coming to the provisional diagnosis, obesity. Uh, Coming to the demographic data, age 32-year-old female, her anthropometric measurements: height is 151, weight is 90.5 kgs, BMI was 39.6. She comes under the category of obesity 2. Ideal body weight is 51 kgs, adjusted body weight is 60.8. So these are her biochemical parameters. Medication which was prescribed during the stay of the hospital, medication chart which was given during the discharge time. Coming to the dietary assessment, a type of diet, liquid diet. Coming to the mode of feeding was oral. Coming to her food habits, she was an excessive intake of processed foods and she was a non-vegetarian. Coming to PES statement, recurrent cough related to GERD, etiology, there is an interconnection between due to her eating pattern. Coming to signs and symptoms, heartburn, nausea, and fatigue. So this is her 24-hour home recall. So calories up to 2007.37 calories, carbohydrate 233.15 grams, protein 85.74 grams, fat 64.42 grams. Coming to our food frequency, cereal, pulses, fruits, sugars and Indian sweets, fats and oil, milk products was taken on a daily basis, while green leaf vegetables was taken on monthly basis. Other vegetables and meat and poultry she was taking on a weekly basis. Coming to the nutritional goals, to allow the staple line of your stomach to heal without being stretched by the food you eat, to help you lose weight and avoid gaining excess weight, to avoid side effects and complication, engage in regular physical activity, improve overall health through few lifestyle modification, through healthy sleep pattern, monitoring and follow up. Coming to the case progression, day one she got admitted where doctor had advised for clear liquids. So we started with some clear liquids. Day two she was posted for the surgery, and day three and day four post surgery she was kept on NPO because to heal the area where she was operated. And day four at 11 a.m. Patient was started on clear liquid diet as well as her tolerance level. Day 5 she was on clear liquid. Coming to day 6, the patient was started on full liquid diet. So this is her 24-hour recall of the hospital. Coming to the bariatric surgery diet, it is designed for people who are recovering from the bariatric surgery to help them heal and change their eating habits. So basically, during the initial post-surgery phase, your diet will you'll be put upon liquid diets, followed by pure diet, and then soft diet based on your tolerance level. So sample menu for a clear liquid diet for the 2 days post surgery. This is the full liquid diet. This is phase 2, pureed form. So according to your tolerance, you can start with pureed diet in a second week of your post surgery. So in this, the consistency should be complete of a pureed form. So from here, you will get approximately 800 to 900 kilocalories. This is the sample menu for the pureed diet. Coming to phase 3, as per as a tolerance level, patient will be put upon a soft to solid diet. So phase 4, after your 4 weeks of the bariatric surgery, you can gradually return to eating firmer foods. You may find it little difficult, so make sure to avoid some spicy foods or foods with crunchy texture. Start taking with small and frequent meals. And try to take small and frequent meals during the diet progression. You need to have small and frequent meals. Maybe you can start with some 6 small meals and then move to 4 meals, and then when you move on to the regular diet, 3 to 4 meals per day is recommended. Take recommendation of vitamins and mineral supplement in a chewable form, because a small portion of your small intestine is being bypassed after your surgery, so you will not be able to absorb enough of nutrients from the food you take. So drink adequate amount of fluids. Try to take your meals slowly, and try new foods at a time post surgery. Coming to the follow up was done thrice on 7th, 12th, and 2nd December through telephonic. First follow up, the patient was tolerating the liquid diet as prescribed, and there was slight abdominal pain. Second follow up, the patient was tolerating well with the liquid diet, so she had started with the pureed diet, but initially she had that symptom of nausea. And coming to the third follow up, the patient had started with solid diet along with pureed diet for 2 days in between her solid meals. Then she tolerated well, and then she continued with solid diet, and slightly physical activity was introduced on a daily basis. So these are my references. Thank you, ma'am.
Can I see your planned diet again?
Sure, ma'am. Ma'am, from here it starts with clear liquids.
Yeah. 10 o'clock. Okay. This is for 2 days. Okay.
Yeah, this is for 2 days, and then followed by for next 5 days she can move to full liquid diet, ma'am, like with the clear liquids. This is for pureed form.
This is see also.
Yes, ma'am.
Just go back one slide. You think 79 gram, okay, you're giving energy only 859, 857, is it? How did
Ma'am,
you
no,
get
that
that
is from the
calorie?
calculated, ma'am, that is from the calculated diet of the pureed food, what I had prescribed.
Supplement is also going, ma'am.
Yes, ma'am, supplement
Yeah.
is also going, like
So how much is
protein.
the
That is
supplement?
giving calorie and protein.
Ma'am, two
So even
scoops
that
is
you must add,
ma'am, I've added in the menu, like
200
sample menu,
calories coming from supplement only.
supplement.
So about 1,000 calories only you're giving this patient.
Yes, ma'am, in the pureed diet, like usually.
In the purine diet. And out of this, only 76 grams is carbohydrate.
Yes, ma'am.
Wait.
So this is for the phase 3, ma'am.
Mm. 8 a.m. is all that or one or.
No, ma'am, actually I have given an option while calculating the
So
total values. I have just taken from each thing one meal, ma'am.
no. See,
Right,
8
or
a.m.
instead of
What is
bullets. Or.
it?
It's or.
Put or. No, then I don't
Please don't
understand
put
the
bullet.
calculation. No? How much did you
She
take for
said
the
she picked up
calculation?
one thing. She said she
Anyone,
picked up one thing
random.
from those.
So in this calculation, which one did you take?
Ma'am, from breakfast I have taken idli. From lunch I have taken thin broken wheat khichdi.
Okay.
And for lunch I have taken something like pongal.
Something like no. What did you take?
No, ma'am, I
No,
have
no,
taken
no,
for
no.
dinner.
This is not
Dinner,
a
I'm taking
relevant
thin broken wheat
answer.
khichdi, ma'am, for dinner.
Yeah, please write only one thing, and it should all be equal calories. It can't be 99 or 155 calories or 85 calories. It's a big swing, no?
Yes, yes, ma'am.
Everything should have been planned for 155 calories at least, if you're
Oh, okay,
using that.
sure.
Okay. Then only
Yes,
you can put even or. Otherwise, you can't even put or now.
okay.
Okay, because it's a solid 155, 85. It's a solid 15 plus 55. Almost 70 calories difference.
Yes, yes, ma'am.
Okay, so just rewrite that properly. Take it all off.
Oh,
You don't need to give so many suggestions. Plan any one thing and use that for your calculation.
calculation. Okay, ma'am. I'll do
Yeah.
that.
Okay. And then even they must get, you've not planned like, okay, veg soup is there, fruit juice. Fruits, they should get a juice, girls. At least once give a
Fruit is
juice.
there, ma'am. 11 o'clock, there's a
Fruit is
fruit.
11 o'clock,
Ah,
ma'am.
fruit is there. Okay, okay. Buttermilk, curds,
Curd I have
those kind of
given.
things. Curd is
Yes,
there.
ma'am.
Yeah. Okay.
Curd I have
Okay, so
added,
just
ma'am, in
write
the
it up
lunch.
correctly. Just write it
Sure,
correctly.
ma'am. I'll do that. I'll do that.
Okay. And please
Pre-surgery,
slow
was
it.
she on any diet for 10 days?
Sorry, ma'am.
Pre-bariatric, pre-bariatric, pre-surgery, before she got admitted, was she on any
Yes,
liquid
ma'am.
diet or anything like that?
Ma'am, usually she told me while the 24-hour recall, all those things, she was like from past 1 week, she was following the clear liquids because she was not feeling like she was not taking enough of solids, ma'am. So she was comfortable taking liquids.
Was she advised that or was she taking that on her own?
No, ma'am, she was taking.
The doctors
Only
usually
clearly.
prescribe them. Yeah.
Yes,
Yes.
ma'am,
So
she was taking
usually 1 week, 10 days before surgery, the patient will be on liquids only.
liquid.
Yeah.
Yes, I think that is not mentioned here, no?
Yes,
Yeah.
ma'am, it's not.
And it is
And
not by choice, Ursula. The surgeon
Ma'am?
generally tells them to take meal replacement
Yes,
along
ma'am.
with more of liquids.
so
Liquids.
the fat around the surgical site will come down a little bit is why they do it.
Okay.
And again, your test statement says FOF, and your case study is on bariatric surgery. There's no connection between the two.
All pest
Okay.
statements, please rewrite, girls.
Sure, ma'am.
That's
I'll make changes, ma'am.
Okay.
Thank you,
Okay.
ma'am. Yes, ma'am.
Okay. Thank you, girls. That was good effort, but just keep to the basics so that you don't deviate too far and get lost in other things. Okay. Thank you. Please write up
Thank
your
you.
corrections. Only after you show it to Sandhya ma'am, come to me for a signature.
Thank you,
Okay?
Daphne ma'am. Thank you, Anisha.